Hello folks, in this part of the chapter we'll be discussing the different states of consciousness. First off, let's talk about the centers in the brain or the regions of the brain that are responsible for the regulation of the states of consciousness. There are 5 different parts of the brain that we want to be familiar with. So I'll introduce them first, and then we will talk about how they work together to keep us awake or to let us fall asleep. So first off, we have this yellow one, and that is known as the suprachiasmatic nucleus, and that is a nucleus that we have talked about several times before in the course. It's found in the hypothalamus. It releases 2 hormones. One of them is known as melatonin, and that hormone puts us to sleep. Another hormone that it releases is orexin, and this is how you spell it right there, orexin. Orexin hormone is the wake-up hormone. So the suprachiasmatic nucleus will actually start making orexin even before you wake up. So if you do not even have an alarm on, the accumulation or the secretion of orexin is going to wake us up without any alarms. Now the monoaminergic or the RAS nuclei. RAS stands for reticuloactivating system. These are the red nuclei, and those are found in the reticular activating system of the brain. They release monoaminergic neurotransmitters like norepinephrine, serotonin, and histamine. All 3 of those neurotransmitters are going to activate the thalamus and the cerebral cortex, and that wakes us up. And when you're fully alert, your cerebral cortex is fully functioning. Remember, you also want to wake up the thalamus. Remember, the thalamus is the gateway for all of our senses except for smell. So when you open up the thalamus, more and more sensory information is going to reach the cerebral cortex, and now you're more alert and more awake. Now down to this green area, and that is the orexin secreting neurons. Those are also found in the hypothalamus, and these neurons secrete orexin just like the suprachiasmatic nucleus does, and that again, orexin will stimulate the thalamus and the cerebral cortex. These orange neurons are your acetylcholine secreting or cholinergic secreting neurons. You could see part of them in the frontal lobe. We've got some neurons inside in the pons. That acetylcholine also is going to stimulate the thalamus and the cerebral cortex. So all of those nuclei are there to wake us up. Okay, we do have a sleep center though. You can see that blue sleep center, and these release a neurotransmitter of GABA. So GABA, or the GABAergic neurons, these release GABA as a neurotransmitter, which was an inhibitory neurotransmitter, and that puts us to sleep as well. This whole aim of all of these different nuclei would be to stimulate the thalamus and the cerebral cortex. Okay, so again, here are all of the different nuclei. So we've got the suprachiasmatic nucleus that's found in the hypothalamus, and that is really the pacemaker of all of our circadian rhythm. Before we wake up, it starts to increase the level of orexin secretion, and before it sleeps, we start making more melatonin. Melatonin has actually been used as to treat insomnia, which is the inability to fall asleep, and it also is used in treating jet lag. Okay, but it works in some patients, not others. It's not really scientifically proven to work. The monoaminergic RAS nuclei, those release neurotransmitters like norepinephrine, serotonin, and histamine. As we mentioned already, they stimulate the thalamus and the cerebral cortex. So your thalamus would be your sensory gateway, and the cerebral cortex is what you want functioning as you're widely awake. And this is the reason that antihistamines can cause drowsiness, okay? Because you are blocking that histamine from these nuclei, and again, histamine is one of the ways that we stay awake. The cholinergic neurons, those were the neurons that were found in the pons and the frontal lobe, and those also stimulate your thalamus and cerebral cortex. Then we have our orexin secreting neurons. Those are in the hypothalamus. Again, stimulate the thalamus and the cerebral cortex. And really important, if somebody does not have orexin receptors, that would lead to a condition known as narcolepsy. So narcolepsy is a sleep disorder or neurological disorder where individuals are very drowsy during the day. They might even fall asleep during the day, and that is due to the lack of the orexin receptors. So their different neurons are making orexin. It's just that they don't have receptors to respond to orexin. Now, this is a model that explains how we wake up or how we stay awake and how we fall asleep. So the part on the top is awakeness, and the part of the story on the bottom is sleep. We'll start with the awakeness. Again, your whole role or your whole aim of staying awake would be to stimulate the monoaminergic neurons. Those make, again, your norepinephrine, serotonin, and histamine, and that would lead to the stimulation of the thalamus and the cortex. So how do we keep these monoaminergic neurons going? There are several ways to do that. Okay, these different criteria or these different conditions stimulate your orexin neurons to make orexin. Now, orexin will stimulate these monoaminergic neurons. When the monoaminergic neurons again are stimulated, they are going to stimulate the thalamus and cortex and also inhibit the sleep center. So not only are you waking yourself up by stimulation of the thalamus and cortex, but you're also inhibiting the sleep center. Now, how are these orexin neurons stimulated? There are several ways, either the suprachiasmatic nucleus in the hypothalamus or negative energy balance. And that means that somebody is trying to go to sleep while they are hungry. So their energy input is less than their energy output throughout the day. Okay, when we're hungry, it's hard for us to fall asleep. And that is because hunger stimulates the orexin neurons. Also, the increase in the limbic system activity. The limbic system is the part of the brain that is really responsible for emotions. So if you're stressed about something, or if you're excited about something happening, or on the other hand, or if you're upset about something. So activity of the limbic system will also prevent us from falling asleep because that would stimulate the orexin neurons and again make it harder to fall asleep. So again, going through awakeness, how do we stay alert? Either the suprachiasmatic nucleus makes orexin, negative energy balance, and increased activity of the limbic system, all of those are going to stimulate the orexin neurons to make orexin. Orexin stimulates the monoaminergic neurons to make norepinephrine, histamine, and serotonin. And those three neurotransmitters are going to stimulate the thalamus and the cortex, plus inhibit the sleep center. Okay, now how do we reverse all that so we can finally fall asleep? Again, it's all about these monoaminergic neurons. You want to inhibit those. You need to stop the norepinephrine, serotonin, and histamine from being released. Now, how do we do that? So either adenosine or other homeostatic regulators. Adenosine is made throughout the day. So our brain cells are always breaking down ATP, and that leads to the accumulation of adenosine in our brain. Adenosine is one of the reasons why you really need to go to sleep so we can get rid of that adenosine, which is kind of like kind of want to think of it as a brain toxin that we have to get rid of as we sleep. So the accumulation of adenosine throughout the day and other homeostatic regulators. For example, think about having an infection. Think about maybe getting sick. When we're sick, our immune system releases different cytokines, different chemicals. One of them is interleukin 1. Interleukin 1 is going to inhibit the orexin neurons. Okay, and that leads to that sleepiness and wanting to just lay down in bed and the fatigue that we feel when we're sick. Okay, so again, accumulation of adenosine, which is a normal process that happens due to the breakdown of ATP by the brain cells throughout the day. Other homeostatic regulators, for example, the interleukins that are produced during an infection, those are going to inhibit the orexin neurons. So there's no more orexin. So we kind of like, let go of that. We stopped stimulating the monoaminergic neurons. And more importantly, it's also going to stimulate the sleep center. Okay, so all of that will inhibit or stop the monoaminergic neurons from making the norepinephrine, serotonin, and histamine. When we do that, we are now no longer stimulating the thalamus and cortex, and that could lead to the relaxation and eventually falling asleep. Now, a little bit on coma and brain death. So coma is described as an extreme decrease in mental function. That decrease in mental function can either be due to a structural or physiological damage, for example, maybe a stroke or trauma, or a metabolic damage to the brain, for instance, due to diabetic ketoacidosis or diabetic coma. So the causes of coma are very variable. Well, brain death, that is where there is no brain function, okay, and no possibility of the brain gaining function again, okay? So that is really important, that when a patient that is diagnosed as brain dead, there's different criteria. We'll go through that in a second, but one of the criteria is, and which is really important, is that there is no possibility of regaining function, okay? Because if there is a possibility, that means that the patient is treatable and you need to treat the patient. So here are some criteria for brain death. I'm not going to go over all of them. I'm just going to kind of touch up on the more important, or the important ones. And there's a little link over here that you can go to, and it gives you a more breakdown of, how many criteria you need and so on. So we use these criteria, like the nature and the duration of coma, they have to be known. Okay, so when you get a patient, say, in the hospital or through the ER and they're comatose, you really need to figure out through, if you can get a history from somebody that saw what happening, or a family member, through blood, through, x-rays, MRIs, or blood tests, or so on. You will have to find the nature, the cause of the coma, because it could be treatable. Again, this could have been a diabetic patient that got into a coma, and it's very easy to treat. Okay, you want to know the duration of the coma. Has it been 5 minutes? Has it been 5 days? What's the range of time that we're talking about here? So again, things can be treated if we know what the cause is. Okay, cerebral and brainstem function are absent. So a brainstem is where we have all of the centers of breathing, heart rate, and so on. So if the brainstem function is there, then maybe we can figure out what the cause is and we can bring this patient back. But if there is total loss of the function of the brainstem, then that is a different story. Okay, now how do we know that the brainstem is no longer functioning? A couple of ways. So the pupils do not respond to light anymore. There's no gag or cough reflex. There's apnea. So if you remove the ventilator, there would be apnea, which means that the patient does not start breathing on their own. And then there's an increase in the levels of carbon dioxide when, again, the ventilator is removed. You want to confirm that neurological exam every 6 hours, okay, before you can make that diagnosis of brain dead. And then there are other criteria. For example, you hook up the patient to an EEG. If there's a flat EEG for 30 minutes, that you could use that as a criteria. Or responses that are absent in the brainstem, and greatly reduced cerebral circulation. So there's really no blood circulating within the brain. And again, this link will take you to more of a breakdown of a lot of these criteria if you're interested. So what is a conscious experience? So we talked about senses in chapter 7, and we said that perception and senses are very different. Now, how is it that the eye, the rods and cones might actually pick up signals, but we do not experience what it picked up, meaning that it might be in our field of vision, but we really didn't see it. We did not experience it on a conscious level. So, and I've got a couple of videos in the recommended material that I would recommend you watch it in order to better understand how that works. So conscious experiences are the things that we are aware of. Okay, we actually know and understand that they occurred to us. Those could be internal experiences like memories and ideas, or they could be external experiences like art or music or an event. We are aware of these different stimuli, and these are our experiences. So these are known as self experiences like fatigue, hunger, thirst, happiness, and so on. Now, what is selective attention? That is the ability to focus on something. So let's say you're taking the test and there is just a little bit of noise happening around you. The ability to avoid these distractions and filter them out while focusing your attention on the question is selective attention. So selective attention means avoiding the distractions of things that are irrelevant at the moment and seeking out and focusing all of your stimuli on what is important at that moment, because what might be important right now might be irrelevant later. So that is again how, if parents are asleep, there might be a train passing by their house and doesn't wake them up whatsoever. But if that baby that, just whimpers or cries a little bit, that would wake them up. Although obviously the noise coming out of a train is much louder. But again, their brain has that selective attention ability where they can filter out the irrelevant train passing by and seek out and focus their attention on that baby that is crying and waking up. Okay. Now, selective attention has been implicated, or the inability, I should say, to perform the selective attention has been implicated in the diagnosis of ADHD. And ADHD is the attention deficit hyperactivity disorder, where it is hard for these individuals to get rid of the irrelevant stimuli. So now they are consciously experiencing everything that is happening in the room. So this is a diagnosis that is usually made in childhood. So in a classroom, there are tons of things that could be distracting. Okay, so there's people walking, other kids that are talking to each other, the teacher's obviously explaining things, and sometimes it's hard to focus that attention and again to go through the selective attention of getting rid of those of all of these distractions, and that could lead to the diagnosis of ADHD. Where again it's characterized by difficulty in maintaining selective attention. Sometimes there is impulsiveness and hyperactivity, meaning doing and saying things that should not be done or said in that particular situation. It is due to a dysfunction in the brain regions where catecholamines signaling is prominent, and that is in particular in the basal nuclei and the prefrontal cortex. So we have these different areas of the brain that are considered filters for motor impulses, and that would normally tell a person that maybe getting up and doing jumping jacks in the classroom is not a good idea at this point because the teacher is trying to explain something. Maybe I can do the jumping jacks later during recess, but again, the inability to filter those motor impulses due to the dysfunction of the basal nuclei and the prefrontal cortex is what would lead that kid to do that at that particular time. Okay. And what supports that theory is that the widely used medicine known as Ritalin, the generic name is methylphenidate. That is a drug that increases the concentration of dopamine and norepinephrine in the basal nuclei and in the prefrontal cortex. And it was found that is a very effective treatment. Now these kids are able to use that filter again, okay, that they regain the function of that filter and are able to filter out what is appropriate to do now and what needs to stay until later on. Okay, although there is a lot of discussion right now in the medical field that ADHD is hyperdiagnosed, meaning that, some kids just have extra energy and they need to let it out. Especially it's overdiagnosed and particularly in boys. So there is a gender bias in here, and there's a lot, you can read more on that through this research paper. So although that is true, but again, when it's properly diagnosed and properly treated, these kids do wonderful. Now, what are the neural mechanisms of conscious experience? So conscious experience needs a lot of nerve processing within the brain. Obviously, the receptors have to pick up the stimuli. These receptors have to reach the cerebral cortex in order for us to experience it. But there has to be integration between the association areas, if you guys remember that, where they temporarily work together in order to give you a full experience. So again, seeing, a piece of art or hearing some music. So those visual or auditory stimuli, they have the ability to give you different emotions, different memories. All of that, again, is due to these different association areas temporarily working together in order to give you that conscious experience. Now here, this is a patient that has right parietal lobe damage. Okay, so although their eye can definitely see this whole image, okay, this patient was asked to draw that image. So there is nothing wrong with their occipital lobe. Okay, remember here that the damage is in the right parietal lobe. So the occipital lobes are totally fine. Their occipital lobes are seeing the whole image, but their parietal lobe is not experiencing the whole image. So when they were asked to draw the image, you see here that they have totally neglected, not neglect because they can't experience it. So it's not an intentional neglect, but there is a neglect of the left side of the image. Okay, remember things crisscross to the opposite side. So in right parietal lobe damage, although their occipital lobe can see it, but they are not experiencing it on a conscious level. And hence again, when they are asked to draw the image, they did not draw the left side of the picture. This ends this portion, and I will see you in the next.